Hello, I am Caron Jacobson from the Dana-Farber Cancer Institute, and I will be presenting the interim analysis of ZUMA-5, a phase 2 study of AXICABTAGENE CILOLEUCEL, or AXI-CEL, in patients with relapsed or refractory indolent B-cell non-Hodgkin lymphoma. On behalf of myself and the other ZUMA-5 co-investigators, I would like to thank EHA for choosing our study for presentation at this meeting. These are my disclosures. Advanced stage indolent B-cell non-Hodgkin lymphomas are largely incurable with conventional therapies, with many patients experiencing multiple relapses over the history of their disease, and with shortening remission duration with subsequent therapies. In particular, patients who relapse within 2 years of their upfront chemoimmunotherapy regimen do less well than those who have longer remissions. AXI-CEL is an anti-CD19 autologous CAR T-cell therapy with a CD28 co-stimulatory domain. It has been approved in the US and in the EU for the treatment of relapsed or refractory aggressive B-cell non-Hodgkin lymphoma based on the results of the ZUMA-1 study. On this study, 83% of patients responded, with 58% achieving a complete response, and many of these responses were durable with 3 years of follow-up. The 3-year overall survival was 47%. ZUMA-5 is a multi-center, single-armed phase 2 study of AXI-CEL in patients with relapsed or refractory follicular or marginal zone lymphoma in the 3rd line and beyond. Patients were eligible if they had grade 1 to 3A follicular lymphoma or nodal or extranodal marginal zone lymphoma that had relapsed after 2 prior lines of therapy, which must have included at least an anti-CD20 monoclonal antibody as well as an alkylating agent. The planned accrual for this study is 160 patients, 125 follicular lymphoma patients, and 35 marginal zone lymphoma patients. The first 80 patients with follicular lymphoma to reach 9 months of follow-up were evaluable for efficacy, whereas all patients treated were evaluable for safety. Patients received lymphodepleting chemotherapy with fludarabine 30 milligrams per meter squared and cyclophosphamide 500 milligrams per meter squared daily for 3 days, starting at least 5 days prior to their CAR T-cell infusion. All patients were admitted to the hospital for AXI-CEL infusion, which was at the FDA-approved dose of 2 times 10 to the 6 CAR-positive T-cells per kilogram. The primary endpoint of the study was the overall response rate in the 80 follicular lymphoma patients evaluable for efficacy. Key secondary endpoints included other parameters of efficacy, including CR rate, duration of response, progression-free survival, and overall survival, safety as measured by rates of adverse events, and CAR T-cell and cytokine levels over time. The marginal zone lymphoma cohort was an exploratory cohort, and all analyses were descriptive in nature. Patients were enrolled in the study at leukapheresis. In total, 148 patients underwent leukapheresis and 140 patients were treated to date. The 8 patients who were not treated included 4 marginal zone lymphoma patients who were pending dosing at the time of the data cutoff, and 4 follicular lymphoma patients, one of whom died of unrelated causes prior to cell infusion, and 3 of whom were found to be ineligible, including one whose optional pretreatment tumor biopsy showed transformation to diffuse large B-cell lymphoma. This patient was ultimately treated under compassionate use circumstances. The median follow-up as of December 16, 2019, among the 80 follicular lymphoma patients evaluable for efficacy was 15.3 months. All patients in this cohort had at least 9 months of follow-up. 16 marginal zone lymphoma patients with at least 1 month follow-up were also evaluable for efficacy. All 140 patients that were treated were evaluable for safety, with a median follow-up of 12.8 months in this cohort. Baseline patient and disease characteristics are shown here. This was a heavily pretreated and high-risk population. More than 50% of patients had advanced stage disease, high tumor bulk, a high-risk FLIPI, or had progressed within 24 months of their first chemoimmunotherapy regimen. More than 2/3 of patients had received 3 or more prior lines of therapy, and the majority had demonstrated refractory disease to their last line of therapy. 1/3 of patients had received prior PI3 kinase inhibitor therapy, and approximately 1/4 of patients had had a prior autologous stem cell transplant. In all patients, by independent centralized radiology review, the overall response rate was 93% with a CR rate of 80%. For the efficacy follicular lymphoma cohort, the overall response rate was 95% with a CR rate of 81%. Although it does appear that the response rate is lower in the marginal zone lymphoma cohort, this is largely due to 19% of patients having been found to not have measurable disease by central radiology review prior to CAR T-cell infusion. Amongst the follicular lymphoma cohort, 13% of patients with an initial partial response to therapy at 1 month subsequently converted to a complete response at a later time point. There were no patient or disease factors that associated with response, although the 13 patients who had relapsed within 6 months of their initial chemoimmunotherapy regimen trended towards a worse outcome. Duration of response for follicular lymphoma, the blue line, and marginal zone lymphoma, the green line, are shown here. Amongst responding follicular lymphoma patients, nearly 80% maintain their response past 12 months. At around 19 to 20 months, this does cross 50%, however, due to 2 deaths that occurred in patients in continued response due to factors unrelated to CAR T-cell infusion or lymphoma. As additional patients reach longer follow-up past 20 months, then, it is possible that this curve and the median duration of response may improve. Similarly, amongst marginal zone lymphoma patients, the median duration of response is 10.6 months, but very few patients have reached follow-up past 6 to 9 months. Progression-free and overall survival curves are shown here. Median overall survival has not been reached, and 94% of patients remain alive at 12 months follow-up. Grade 3 or higher adverse events were common, but the majority were related to cytopenias. There were 2 grade 5 adverse events in patients with follicular lymphoma on this study. 1 patient died of an aortic dissection unrelated to AXI-CEL, and 1 patient passed away as a result of multi-organ system failure in the context of cytokine release syndrome. In total, 79% of patients experienced cytokine release syndrome of any grade. In 8% of patients, this was grade 3 or higher. Although the numbers are small, the incidence of any grade or high-grade cytokine release syndrome appears to be higher in the marginal zone lymphoma patients. Almost 1/4 of patients with follicular lymphoma did not experience any grade cytokine release syndrome, and only 7% of patients with follicular lymphoma experienced grade 3 or higher cytokine release syndrome. Fever and hypotension were the 2 most common manifestations of cytokine release syndrome, with tocilizumab and/or steroids used in 47% and 17% of patients, respectively. The median time to onset of CRS was 4 days, which was later than what was seen with AXI-CEL on the ZUMA-1 study, and the median duration was 6 days. Considering all 140 patients treated, the incidence of neurologic toxicity of any grade was 58%, with grade 3 or 4 neurologic toxicity in 17% of patients. Again, the incidence of any grade or high-grade neurotoxicity was higher in marginal zone lymphoma patients, with only 15% of follicular lymphoma patients experiencing grade 3 or 4 neurotoxicity, compared with 38% of patients with marginal zone lymphoma. The most common manifestation of neurotoxicity were tremor and confusional state, and 34% of patients received corticosteroids to treat neurotoxicity. The median time to onset was 7 days, and the median duration was 14 days. There were 4 ongoing events at the time of data cutoff, all in follicular lymphoma patients, including grade 1 and grade 2 paresthesias, a grade 1 attention disturbance, and grade 1 memory impairment. CAR T-cell levels were tracked over time and peaked on day 8 after infusion. Peak CAR T-cell levels were similar to that seen on ZUMA-1, but note that the peak CAR T-cell levels were slightly higher and occurred slightly later in the small number of marginal zone lymphoma patients treated. CAR T-cells were detectable in 87% of patients with evaluable samples at 18 months of follow-up. Peak CAR T-cell levels were similar amongst responding follicular lymphoma and marginal zone lymphoma patients. There were too few non-responding patients to adequately assess a relationship between peak CAR T-cell levels and objective response. However, patients with follicular lymphoma who had an ongoing response at 9 months had higher CAR T-cell expansion compared with patients with relapsing or primary refractory disease. Patients who experienced grade 3 or higher cytokine release syndrome or neurotoxicity did have higher peak CAR T-cell levels in both follicular lymphoma and marginal zone lymphoma patients. In follicular lymphoma, where the numbers were larger, this association was statistically significant for both high-grade CRS as well as neurotoxicity. Serum cytokines were measured over time and correlated with rates of high-grade CRS and neurotoxicity. Patients with follicular lymphoma who experienced high-grade CRS and/or neurotoxicity had higher peak levels of several cytokines, including interferon gamma, IL-2, IL-6, GM-CSF, and MCP-1, amongst others. In conclusion, AXI-CEL yields high rates of response in indolent B-cell non-Hodgkin lymphoma with an overall response rate of 93% and a CR rate of 80% in multiply relapsed follicular lymphoma and marginal zone lymphoma. Although longer follow-up is needed, these responses appear to be durable amongst follicular lymphoma patients who achieved a CR. 80% remain in response at the median follow-up of 15.3 months. Given the long natural history of these diseases, safety is of paramount importance. The safety profile was manageable and reversible and appeared to be at least similar to that of AXI-CEL in aggressive lymphomas. Of note, though, patients with follicular lymphoma appear to have lower rates of high-grade CRS as well as neurotoxicity compared with marginal zone lymphoma, and this compared favorably with the results of ZUMA-1. Furthermore, up to 23% of patients with follicular lymphoma did not experience any cytokine release syndrome, and the median time to onset of CRS was 4 days. This compared favorably with the median time to onset of CRS of 2 days on ZUMA-1. This may have implications for the possibility of outpatient therapy. Longer follow-up is needed to determine durability of response, and the primary analysis with 12 months of follow-up is currently ongoing. But AXI-CEL appears to be a promising therapeutic approach for patients with relapsed or refractory indolent B-cell non-Hodgkin lymphoma. I would like to thank Kite and all of my co-investigators and study staff at each study site for their contributions and support of this study. Most importantly, I would like to thank the patients and their family and friends for their participation and generosity, without whom the study could not have been done. Thank you.